All right. Can you all hear me okay? Good morning, everyone, and welcome to our Pediatric Discovery Day. It's a particularly exciting day for us. We can celebrate science broadly throughout the Department of Pediatrics and at UPMC Children's Hospital. We're going to hear an exciting keynote talk, and this talk will be followed by presentations from some of our fellows and junior faculty, again, to celebrate science around child health. It's a really terrific day. I want to give some thanks before we start. I want to thank Becky Chiaffi and Savannah Ryder for their impeccable organization of this day. And then I also want to thank Tracy Kasmersky, who serves as our training director for our NICHD funded T32, and Linda McAllister, who serves as training director for our NICHD funded K-12 program. And so Tracy and Linda have organized the speakers and will be facilitating discussion later this morning. So thank you all. What a pleasure to introduce my colleague, Dr. Diana Bianchi, who's going to give our keynote talk today for Pediatric Discovery Day. Dr. Bianchi is director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development at the National Institutes of Health. I want to just tell you just a bit about Dr. Bianchi and her accomplishments. She is an internationally recognized leader in prenatal genomics with the goal of advancing non-invasive prenatal DNA screening and diagnosis to develop new therapies for genetic disorders. Dr. Bianchi and her team seek to advance understanding of fetal and placental biology through sequence analysis of nucleic acids that circulate in the pregnant women's blood. The information acquired then is used to improve counseling as well as prenatal care. Of the many contributions of the Bianchi Laboratory, I find the work on developing prenatal treatments for Down syndrome particularly exciting. Dr. Bianchi's research has uncovered the existence of significant oxidative stress, cell cycle defects, and neuroinflammation in children with Down syndrome in utero. Of course, these findings set the stage for development of prenatal treatments to ameliorate these effects with the goal to improve postnatal cognition and behavior. This is just amazing. Now, Dr. Bianchi received her MD degree from Stanford and completed postgraduate training in pediatrics, medical genetics, and neonatal and perinatal medicine at Boston Children's Hospital and Harvard Medical School. Prior to her time at NICHD, she spent 23 years at Tufts University School of Medicine, where she was the founding executive director of the Mother Infant Research Institute and the Natalie V. Zucker Professor of Pediatrics, Obstetrics, and Gynecology. Dr. Bianchi has received numerous awards for her work, including the 2015 Neonatal Landmark Award from the American Academy of Pediatrics, the 2016 SPR Maureen Andrew Mentoring Award, and then the 2017 Colonel Harlan Sanders Award for Lifetime Achievement in Medical Genetics from the March of Dimes. Now, in directing NICHD, Dr. Bianchi oversees an annual budget of approximately $1.7 billion in support of the NICHD mission to lead research and training to understand human development, improve reproductive health, and enhance the lives of children and adolescents. We are grateful to Dr. Bianchi and NICHD for supporting our T32 and K-12 programs, of course, as well as numerous research projects in the Department of Pediatrics at UPMC Children's Hospital and really throughout our institution. Now today, Dr. Bianchi is going to discuss new work from her team that has enabled us to provide better care for mothers and children. The title of her seminar is Prenatal and Neonatal Precision Medicine, the earlier, the better for mom and baby. Diana, welcome to Pittsburgh.
Hey, good morning, everyone. Can you hear me? Okay, wonderful. So great to be in person, isn't it? I've given a limited number of in-person talks, very, very comfortable with being my own AV support person, recording talks at home, doing everything. But it's great to be here, and I look forward to meeting with all of the researchers. And I would like to thank you for inviting me and for the support staff who've done a wonderful job of organizing the day. So let's see. It's going to, okay, how are we going to advance? It's frozen, or maybe down here. Okay, I see now where it's. Okay, I'm going to start with my former boss, Dr. Francis Collins, who stepped down as director of the NIH over a year ago now, and we still don't have a new director. And people ask me, well, who's going to take over? And we do have acting director, Dr. Larry Tabak, who's doing a great job. But Francis is very much around, and in fact, he is in the same center as I am in. So I really have two jobs. My day job, as I call it, is director of NICHD, but my other job is as a senior or tenured investigator in the Center for Precision Health Research. And that's what I'm going to tell you about. And that center is in the National Human Genome Research Institute. So back in 2010, Francis Collins wrote, "We're on the leading edge of a true revolution in medicine, one that promises to transform the traditional one-size-fits-all approach into a much more powerful strategy that considers each individual as unique and having special characteristics that should guide an approach to staying healthy." And I can just imagine hearing him say this. If you're interested in living life to the fullest, it's time to harness your double helix for health and learn what this paradigm shift is all about. So he said that in 2010, and it's already happening. So there are already paradigm shifts in pediatric and prenatal care that harness the double helix. So today I'm going to be talking about two areas of research from my laboratory at NHGRI. We're going to start, as Dr. Dermody highlighted, we're going to start with how we're using gene expression analysis to develop novel therapies to be given prenatally. And then follow up with how there really has been a paradigm shift in prenatal care, particularly in screening for aneuploidy. But what is the next step in that research? And I like this picture because I am double boarded in medical genetics and neonatology. And that was something that when I was training, people just couldn't imagine, why you would want to do that. But in fact, it turns out, okay, here we go again. In fact, there already have been rapid advances in newborn sequencing that are part of neonatal care now. So I'm sure in your NICU, if it's not happening now, it's going to be happening soon, that babies who do either have congenital anomalies and for example, don't have an obvious syndrome, will get DNA sequencing. And we have funded at NICHD a number of research projects showing how effective the DNA sequencing has been in terms of making a diagnosis, changing care, sending babies home for hospice if they have a lethal anomaly, and importantly, providing information for the family. So that has already occurred. I'm not really going to talk about that because that's part of care. I don't know why this pointer is not doing what it's supposed to. But anyway, I'm going to be talking first about the baby since we are pediatricians, and I'm going to be talking about the opportunities in prenatal health. Well, back in 1975, that's the first written documentation of fetal therapy. This woman here, Dr. Mary Ampola, who is a retired, she's up at the top, a retired biochemical geneticist, gave this woman, Mrs. Murphy, an injection of vitamin B12 because she had previously lost a child to methylmalonic acidemia. She was pregnant at the time with this person, April Murphy, who has given me permission to use her name. And April, it turned out it was vitamin B12 responsive methylmalonic acidemia. April did well, is intellectually normal. And interestingly, she showed up at the NIH in her 40s as part of a natural history study. So I've gotten to see her. This picture was taken over 20 years ago. So at Tufts, we had a history of fetal therapy. I've been interested in fetal therapy, as you'll hear at noon when I give a talk about how I couldn't decide between going into obstetrics or pediatrics. I've always been at that interface. Most of my research career has been in prenatal screening, prenatal genomics, but as a pediatrician, I'm much more interested in treatment. So back in 2012, we started thinking about genomic diagnosis and how we could apply that to personalized fetal medicine. But the question was where to start and what condition to focus on. Well, we landed on trisomy 21, as Dr. Dermody said, because of several reasons. First of all, prenatal screening and diagnosis for trisomy 21 is part of standard care. At least all pregnant people are offered the opportunity to screen for Down syndrome as well as other major aneuploidies. So it's a situation where we would know ahead of time in many cases that the fetus has Down syndrome. We've also done work this is the work at Tufts of Tomo Tarui, who is a fetal neurologist, who in collaboration with our group has been studying MRIs on living fetal patients with Down syndrome. And there is atypical brain development. I guess the pointer is working for the online people, but not for the live audience. So if you look on the right, you can see, first of all, that the brain is smaller. These are third trimester brains, again, of living fetuses with Down syndrome. The brains are smaller, the orientation is different, and particularly the cerebellum begins to really slow down in growth in the third trimester. So to me, that's one of the most persuasive arguments for why we should be treating prenatally to begin to offset some of those changes. And importantly, postnatal treatment has not been successful, and I'll explain why I think one of the reasons for that. And I also want to mention that the goal is not to dramatically change the lives of people with Down syndrome. What we're aiming for is an improvement in IQ of 10 to 15 points, which would improve independent life skills. So that's really what our goal is. Okay. All right, so our overall hypothesis is that using a personalized approach, personalized for each fetus, that if we give prenatal treatment to the pregnant woman, that would result in improved fetal brain growth, connectivity, and improved neurocognition, again, improving these independent life skills. So if you look on the left, you can see the top line there is the euploid fetus in the second and third trimester, and the acceleration in brain growth. And you can see in the bottom line there that the fetus with Down syndrome begins to really slow down in terms of not only brain growth, but migration of neurons, myelination, and increased apoptosis. So the goal is to get to the red line where you would have a treated fetus paralleling what would be more typical growth. This is not an easy project because now we have two patients. We have to be considerate of the mother, and we also have two barriers to cross. We have to cross the placenta, and then we have to cross the blood-brain barrier in the fetus. So it's not for the faint-hearted. So we started here, and you'll be seeing the right half of the slide in a little while. We started with looking at cell-free RNA that was present in amniotic fluid from fetuses that were having amniocentesis. And this is a great way to start because it's not fetal research. The amniotic fluid specimen is a maternal specimen. Once the karyotype is obtained, then those samples were discarded. So we had confirmed karyotype information on these fetuses. We knew the gestational age, we knew the sex, and we could study the transcriptomes of these fetuses. But the amniotic fluid contains cell-free RNA from a variety of organs that you can see on the top. So there's brain RNA, there's heart RNA, their stomach RNA, et cetera. To make a long story short, we decided to be different in terms of our research. A lot of research on Down syndrome is focused on single genes, but Down syndrome is a very complex multi-gene disorder. And although there are 3 copies of chromosome 21, there are many downstream effects that affect gene expression on other chromosomes. So we decided to take a pathway approach and decided to look at what are the pathways that are involved and how can we treat those pathways. So oxidative stress and neuroinflammation kept jumping out every which way in every analysis that we did. These were the major problems. So we hypothesized that the oxidative stress and the neuroinflammation resulted in damage or a restriction in growth of neural stem cell progenitors. So our goal was to treat these pathways, not the single genes, to rescue the neural progenitor cells and then hopefully restore brain growth and connectivity. So we, our results initially were published in PNAS. So we then became available. Are people having a hard time hearing? Oh, this is for the pointer. Okay, great. Thank you. We then took the gene expression data, the transcriptome data, and plugged it into a resource called the connectivity map, which I should have explained on the previous slide. It's a publicly available resource that was developed by the Broad Institute. It takes gene expression data and plugs it into a variety of cell types and then predicts. At the time, it was using 1,500 FDA-approved compounds to determine what drugs would theoretically have a therapeutic effect. And it presents its data on a scale of -1 to +1. And the goal is to find a compound that has a score that is the most negative, that negates the phenotype of Down syndrome. So this was just a list of candidate compounds, and we're looking for the one that has the most negative effect. The ones that are positive would mimic the transcriptome of Down syndrome. So you can see here that apigenin was our top candidate, but also importantly, there are different scores depending on what tissue you're looking at. But they're importantly negative in neurons, not negative in the cerebellum, but generally negative as compared to some other compounds that had been tested in clinical trials in Down syndrome that did not work. So we looked at apigenin, whatever we use has to be safe to administer to pregnant people. It turns out that apigenin is a natural flavone. It is also known as 4'557 trihydroxyflavone, and it has no known toxicities, and it's also already been studied in humans, which is all good. Not pregnant humans, but humans. And it is known to have potent antioxidant, anti-inflammatory effects. It occurs in leafy green vegetables and citrus fruits. And it's already been studied in, this is interesting to do this two-handed because I want to do it for the people online. It's also been studied already in mice, and it's been shown to cross the blood-brain barrier. And it promotes neurogenesis, which is exactly what we wanted to do, and improve learning and memory in adult mice for a completely different topic. But our lab, I came relatively late to mouse research. I really, I'm not crazy about mice, but I recognize that they're very important for this type of work. So we're also using human cells, starting again with amniocytes and then creating iPSCs to look really at an integrated approach, looking for common dysregulated genes in both humans and mice. Well, speaking of mice, if you're in the Down syndrome research field, everybody's got their favorite mouse. And our most recent paper that's gone online in the last couple of weeks is a study that was published in Biological Psychiatry really shooting down the mouse model that's been used for 25 years. That's a mouse model called TS65DN. And we believe that that's the reason why none of the human trials have worked, because it turns out there are 45 genes in that mouse model that have nothing to do with human chromosome 21. They map to the brain, and they are clearly impacting development in that mouse model. So all of the treatments, the great majority of treatments, have been focused on that mouse model. So many, many years of clinical translational work came to nothing because they were using the wrong mouse model. That's a separate story. I could speak for an hour on that. But we decided for our first trial to use the TS1 CJE mouse model for several reasons. We need a mouse that has a prenatal phenotype. The TS65DN does have a prenatal phenotype, but it's the wrong model. There's a newer version of TS65DN, and that's what we use in the more recent study, that does not have those extra 45 protein coding genes. But the TS65DN has growth restriction, and it has cardiac defects, as you can see here. And it's important to us that the males are fertile. They're hypofertile. And that's a little bit different from human Down syndrome, in which human males with Down syndrome are infertile. But we need to use a wild type mother, because if you use a mother that's affected, they don't foster their pups in the typical way, and it's very hard to study mouse behavior if the mother has the equivalent of Down syndrome. So we documented, we've studied 4 different mouse strains extensively, and decided that TS1 CJE and the newer model, TS66YA, are our mouse models of choice. But back in 2015, 2016, 2018, we were using the TS1 CJE because they do have the prenatal phenotype, and they have abnormalities in a variety of mouse behavioral tests. And this is important because you're going to see the effects of mice that were not treated versus mice that were treated. So here are some of the results. So what I want to orient you to here is a little hard to see from a distance, but look at the gold bar versus the red bar. So the gold bar are the mice that are the TS1 CJE that have received powdered chow without apigenin, and the red bars are the mice that have received powdered chow with apigenin. The black are the wild type untreated, and the gray are the wild type treated. So we use Luminex technology to analyze protein levels, and we're going to show that here are some of the pleiotropic effects of apigenin. So again, we're trying to reduce inflammation. And so the pro-inflammatory cytokines, interferon gamma, IL-1A, IL-12, P70, are reduced through inhibition of NF-kappa signaling. So what I want you to see, and again, is, I don't know, I'm right-handed, so it's hard to do this with both hands, but you can see here that here's IL-12, P70, that it's statistically significantly reduced. Here is IL-1A, interleukin 1A, again, reduced in the treated mice. Now, we're trying to reduce inflammation. So we're looking at the cytokines interleukin 10 and IL-12, P40. So anti-inflammation is increased. Here it's very dramatic. For example, here you see the untreated versus the treated. It works in the wild type mice as well, untreated versus treated. And then we also saw increased expression of angiogenic factors, which perhaps has a therapeutic effect because it's providing more blood vessels to the brain. In addition, we're interested in how does gene expression how is gene expression affected by the treated mice? So here, again, I want to orient you. The black triangle is TS1 CJE untreated mice. These are in the brains of the mice. And I should have mentioned before, those are the brains of the embryonic mice. The red are the treated. The euploid are in circles. Black are untreated. Red are treated. So you take a gene here, KCNJ6. You can see here that the treated mice, the gene expression is much more like the typical euploid mice. Again, a little bit of a therapeutic effect, even in euploids. Here is another gene and another gene. I can't even read them from there. So I want you to see the trend, basically, that with the treatment, quite a number of these genes, some less so than others, but the expression of these genes is much more typical in the treated brains. And I should mention that these mice are receiving, so from the time of mating, the wild-type dam has been mated to the TS1 CJE male. From the time of mating, the dam is receiving the chow with the apigenin in the treated arm, and the untreated arm is just receiving the exact same chow, but without the apigenin. And here are the behavioral data. Again, a little bit easier to see here. Gold is TS1 CJE untreated. Red is TS1 CJE treated. In this case here, it's white is wild type, gray is the wild type treated. Here it's black. And in neonates, we're using a variety of tests, testing their ability to remember where there's a piece of cotton that's been impregnated with the mother's urine. So they're supposed to migrate towards the smell of their mother, and we are measuring the amount of time that it takes them to remember where their mother has been. And the treated neonates here, it takes less time for them to migrate to that piece of cloth. So that's in neonates. We continued treatment through adulthood at 6 to 8 months of age. And here's where, interestingly, we see a sex difference. Sex difference in Down syndrome has really not been explored further. And I think this is another reason why postnatal treatment has not worked. I moderated a session at the Trisomy 21 Research Society meetings in which some of the parents were talking about clinical trials in which their children had participated. And there was great variation in terms of how their children had reacted to the drug. They never looked at sex differences. Some children actually had tremendous benefits and others had none. But I guess if you're a drug company, you've got to make a go, no-go decision. And since there wasn't a consistent effect, they abandoned that particular compound. With the open field test, which is looking at how a mouse is exploring the periphery of a box, the exploratory behavior, again, as you see here, they become less hyperactive. At least the males become less hyperactive. The females become slightly more hyperactive. Again, an argument for precision medicine. Maybe one compound is not going to work for everybody. But as you'll see at the end, if we do this on the basis of genetic diagnostic testing, we would know the sex of the fetus as well as the karyotype. Here's the fear conditioning test, which tests the mouse's ability to remember that he or she got a shock in a particular location. So the normal reaction is to freeze. So here's the percent freezing on the y-axis. You can see here, untreated versus treated. Even better, the treated male mouse here does better than the euploid mice. Females, no effect. So based on this preliminary proof of principle experiment with apigenin, we were thrilled that the first compound that we tested actually showed some therapeutic effects. And as I mentioned, it appears that the targets for oxidative stress, neuroinflammation, and reduced neurogenesis are appropriate. And we're hypothesizing that there are cell cycle defects In neural stem cells, there's increased reactive oxygen species. There is an increase in pro-inflammatory cytokines from reactive astrocytes. And this is activating microglia, which are then impeding the further growth of neurons. We think that the mechanism is that apigenin is reducing neuroinflammation. It's promoting the anti-inflammatory signaling and is promoting the expression of typical neural genes and angiogenesis, which we do think has some effect on the brain. And it's changing the type of microglia from a more neuroprotective microglia to instead of the neurotoxic microglia. So we're encouraged by that first approach. And so one of the criticisms that we received was that we based everything on our study of gene expression in amniocytes, and that's not a target tissue. So the laboratory has spent now 2+ years taking fibroblasts, making iPSCs, and then converting them to neural progenitor cells. And there, in the meantime, has been an even better public resource actually developed by the National Human Genome Institute called NeuroLinks, which is using neural tissue as the base to predict what compounds will improve growth and differentiation. So now we have a more specific cell type and we have a more specific database to look at and explore compounds. So that's what we're doing now. And we expect that we will go back with a variety of new compounds. We now have 19 different NPC cell lines from both males and females, which is the largest collection of what anybody has in Down syndrome. And I don't want to minimize it because it's been an enormous amount of work to create those. So where does that take us? The vision for a human prenatal clinical trial. It will start with prenatal screening and diagnosis of Down syndrome, and we'll get into the prenatal screening, the second part of the talk. If you have a positive cell-free DNA screen for Down syndrome, you should be having a diagnostic test. So either a CBS or an amniocentesis, which would allow us to get fetal cells for personalized precision therapy. So our goal is not to have one size fits all medication. It's not going to be just apigenin. It'll be a variety of compounds, and we will test those cells with those compounds to determine what is best, what is safest for the pregnant person. And some of the early clinical endpoints, one of the reasons why we were looking at the brain MRIs in living fetuses is we now know the baseline. So we would like to be able to study these pregnancies in treated women to show that we're actually, how cool would that be in utero to be able to show that the fetal brain is growing. And there's some early work by investigators at the University of Texas Southwestern looking at the ability to detect fetal mRNA transcripts in maternal blood. So that would be another way to look at the expression non-invasively in pregnant people. And I'll explain, if you're coming to my How Did I Get Here talk at noon, this is Michael Herzenberg, who's the son of my medical school mentors, Professors Lee and Len Herzenberg. He was their first son, born in 1960. And when I entered the lab at Stanford Medical School, they said, we want you to develop a non-invasive prenatal test for Down syndrome. I never met him when I was a medical student. I met him many years later, but he's really been the inspiration for this work. So this is the first half of the talk, the summary. So I hope you're intrigued to think that a prenatal therapeutic approach may correct or mitigate abnormalities before they cause significant irreversible brain damage. I've shown you that it's occurring prenatally. We've used the transcriptome to develop testable hypotheses regarding FDA-approved molecules. NeuroLinks has many more than 1,500 molecules in it. And we're using this integrated approach with both human cells and different mouse models. And we tested first with apigenin on the TS1 CJE mouse. And we were very fortunate that there are many therapeutic effects, and also the fact that there are underappreciated sex differences. So we also hypothesized that these newer bioinformatics approaches may really refine our approach and find even better therapies. So that's the baby. Let's go to the mother. So one of the things that I feel extremely fortunate about is that the medical school project that I was assigned by Professor Len Herzenberg actually has translated into a test. Maybe some of you have had it in the audience, but it has really revolutionized prenatal screening for aneuploidy. And how did that happen? Well, around 2008, 2009, massively parallel sequencing became affordable for individual laboratories. And then it was Dennis Lowe at the Chinese University of Hong Kong and Stephen Quake at Stanford, who simultaneously hypothesized that you could use massively parallel genomic sequencing and use it as a counting system to look for the ratio of fragments that are mapping to, say, chromosome 21 versus a reference. So instead of sequencing, looking for a base change or a single gene mutation, what's done is fragments are sequenced and mapped, and then the mapped fragments are counted, and the ratio is used to predict whether or not the fetus is going to have trisomies 13, 18, 21, the X or the Y. And in many cases, at least in the United States, they're also looking at fetal sex and sex chromosome abnormalities. Turns out in 10 years, so it's just over 10 years that this has been clinically available, tens of millions of pregnant people have been screened using cell-free DNA. And it is by far, and I should have said at the very beginning, I have no conflicts of interest. I am a fully scrubbed federal employee. So none. It is the most accurate screen for fetal aneuploidies with a positive predictive value of over 90% for all pregnant people and a negative predictive value of over 99%. So what does that mean? If you are a pregnant person and you get a result that says positive for trisomy 21, there's a greater than 90% chance. It's even higher if you're older. But there's a greater than 90% chance that the fetus really does have trisomy 21. But the power of this and why it's been so great is if you get a negative result, even if you're 42, you don't need to have an amniocentesis if all you're concerned about is trisomies 13, 18, 21, or X and Y. And you do get the fetal sex if you want it with this test. And that turns out that's what most people really want to know. And, don't get me started on the gender reveal parties. It's a multi-million-dollar business. And it came out of cell-free DNA testing because it's so accurate. Okay, but believe it or not, I'm not going to be talking about, I'm going to talk about the next step, because over the 10 years, this has become incorporated into standard care. It's still not the first tier for prenatal screening in every part of the United States, but in California, it is. And in Belgium and the Netherlands, it is. And it will be eventually, because for those of you who've had the serum screening, the biochemical analytes, the positive predictive value of that test is 5% as opposed to 90%. So that results in a lot of unnecessary amniocentesis. So the clinical cytogenetics labs are not happy, but it's really a better, safer test for pregnant people. So there's a reduced risk of procedure-associated miscarriage. And globally, it has significantly reduced the number of amniocentesis. So again, California, which is, I always say it's like a small European country because it has 470,000 births per year. It really is bigger than many European countries. They just moved to using cell-free DNA as their first tier screen. Okay, so where's it coming from? So both the pregnant person and the fetus are producing cell-free DNA from apoptotic, necrotic, and actually growing cells. The maternal DNA, so we all have circulating DNA in our plasma. It's coming from our bone marrow predominantly. The fetal DNA originates in the placenta. And so you're really getting a liquid biopsy of the placenta. It's not the fetus, and it can, in rare cases, differ from the fetus. So we are performing the sequencing on a mixed sample. The average sample is going to contain 90% maternal DNA and 10% fetal DNA. And we are sequencing both of them together. And you can't tell what's what unless there's Y chromosomal DNA. That's clearly from a male fetus. You can have paternally inherited single nucleotide polymorphisms. That's from the fetus as well. But we're really basically taking these naturally fragmented pieces of DNA, sequencing them, mapping them to parts of the human genome, and then counting the ratio. If the results are abnormal, then you proceed to a diagnostic test. And what happens if they're normal? So this is where we're going into the next phase, because what I just told you about is already in clinical care. So what's the next research question? Well, from the very beginning, and it's been so interesting riding this wave because there's been a lot of resistance. There are a lot of practitioners, laboratories, companies that were very invested in the status quo. Serum biochemical analytes followed up, a lot of false positives followed up with diagnostic testing. So back in 2013, we started to see reports in the literature of false positive cell-free DNA results. And people were saying, this is not ready for clinical care. Look at all the false positives. Well, it turns out they were biological positives. They were just not from the fetus. So there are various explanations for why you might get a result in the cell-free DNA that's abnormal with a normal amniocentesis. So you can have confined placental mosaicism, where there are colonies of aneuploid cells in the placenta. Those are being shed into the maternal circulation. You can have true fetal mosaicism, or you could have a pregnancy that started out as twin, and one of the twins died with an aneuploidy. But what we've been very interested in now is the maternal DNA, because as I said, 90% of the circulating DNA is coming from the mother. And the more you learn, the more interesting it gets. The mothers can have copy number variants. We have found a number of women, particularly who are Turner mosaics with sex chromosome aneuploidy. So Turner mosaics are much more fertile than I learned in genetics. So I was a practicing medical geneticist. So some of these women are pregnant. Also, there are a significant number of people who are mosaic trisomy for an autosome, particularly trisomy 8. Again, I would have never expected this. These are women who are normal intellectually, physically, happen to have cell-free DNA because they're pregnant and they're mosaic trisomy 8. A number of conditions, particularly for autoimmune conditions, can fragment your DNA and cause abnormal results. But my favorite, though, is women who've had a previous solid organ transplant. This is why I didn't go into OBGYN, because the OBGYN doesn't realize that they've had a transplant. They're not looking at the scar on the back there. So what happens is you get a cell-free DNA result, normal male. Then the woman goes for an ultrasound at 19 weeks of gestation. Oh, the baby's female. And everybody freaks out. But nobody mentioned on the history that the mother had a solid organ, a kidney transplant from her brother. So she's got a male kidney that's shedding DNA into the circulation. So that's one thing. We've also seen women with disorders of sex differentiation who are 46XY, who have conceived with assisted reproductive technology. So they should not be having this test because their DNA will be 90% 46XY. So we've seen all these kind of crazy things. Fibroids, as they're undergoing malignant change, will shed very abnormal DNA that can throw it off. But I'm going to talk about malignancy in the remaining moments here. So back in 2015, I was collaborating with the large Illumina clinical lab that was doing cell-free DNA testing, and we became aware of women who had these false positive results. Their physicians called the laboratory and said, could it be that the reason for the abnormal results is the woman has had cancer now? So we went back, I reconsented these 10 women. It turns out we're already testing the whole genome. It's just that for some of the clinical laboratory algorithms, they mask chromosomes other than the target chromosomes, 13, 18, 21. So there's a lot of information under that mask. So we were reconsenting these women to say, can we open up your results? We don't have to take any more blood. We just want to see what's going on there. And of course, they all said yes. And they had a variety of tumors, and I'll show you what some of these profiles look like. Subsequently, there have been a number of other both industry laboratories and national laboratories. So I put the flags here so that you would see in the Netherlands and in Belgium, for example, where there is first tier cell-free DNA testing, they have been reporting on retrospective analyses that the women who have these unusual results could have cancer. It doesn't work in the United States because we have so many different approaches to this. So we've recently written about all the challenges in the United States. We have many different laboratories, mainly commercial. Each one of them analyzes and reports the results differently. There's no standard. There's even a debate as to whether the results suggesting that a pregnant person, and by the way, these people are asymptomatic, whether the person has cancer or not. Should we say something to them? There are no evidence-based guidelines. And back in the beginning, when we would refer these women to oncology, they were like, you're healthy, you're pregnant, you don't need to see me. Wrong. The other thing is to do the appropriate workup. Insurance companies won't pay for it. So I actually, before I came to the NIH, was beginning an R01 application to try to study this, and I realized it was going to be very, very expensive. And then the other thing is the pregnant people themselves, particularly if they're in their first pregnancy, they don't want to be bothered. I want to enjoy my pregnancy. I don't want to be worked up for cancer. We do see a difference in women who have children at home who want to be worked up and treated so that they can be around for all of their children. And what's in the literature is an incomplete workup. And we think that that's falsely reassuring. So we are running a study called IDENTIFY, which is an acronym for Incidental Detection of Maternal Neoplasia through Non-Invasive Cell-Free DNA Analysis. Multiple parts of the NIH are contributing to this. And we are trying to address the diagnostic and management challenges that are present in the US and to obtain the best approach, get the data so that insurance companies would pay for the workup, but importantly, beginning to try to understand what are the genes that are expressed, what are the patterns of DNA sequencing that would suggest this is cancer versus a fibroid, and then evaluate the risks versus benefits of detecting cancer in healthy pregnant women. There are companies that their whole funding plan is really based on the supposition that if you detect cancer early, if you screen for cancer in everybody and treat it, you will have a better outcome. We're doing this on a platform that really wasn't designed for cancer detection, but it actually works, as I'll show you. So why is our study different? It's prospective. So we don't know when our participants come into the NIH whether they have cancer or not. They all look incredibly healthy. You would never know that they have cancer. We are able to fly them in from all over the United States. We pay for their transportation, their lodging, the entire workup, and they can bring a support person as well. We have a common protocol, which none of the other studies have done, and we are using one laboratory. So they come in having had their testing from a variety of different laboratories, but we're using one laboratory so we can compare apples to apples. And we are blinded because everybody's blinded. We don't know what the woman has until we complete her clinical evaluation. And in addition, we're doing a qualitative analysis of the participant experience. And we're able to follow these women for 5 years because some of the women, we don't get a diagnosis, but we're able to follow them. So I'm going to just show you what some of these results look like. So this is kind of insider baseball, but some, as I mentioned, some labs are only looking at 13, 18, 21. They're masking their results. It's different in Europe because they're using a bioinformatics platform called WISE Condor, where you can easily see right away which chromosomes are involved and whether it's a pattern that might suggest cancer. So again, here's the NIH campus. We bring women in who are over 18 years old. They have to be asymptomatic with an abnormal or non-reportable cell-free DNA result. Their fetus has to look normal, so the explanation cannot be fetal. Either they've had diagnostic testing or the fetus looks normal on ultrasound. We bring them in preferably while they're pregnant, but they can be up to 2 years postpartum. Again, it's almost tax time. Your tax dollars are paying for this study. So think about that, how we're saving lives when you pay your taxes. And we can even take women coming in from other countries, but they have to pay for getting to the port of entry in the United States. This is Amy Turif, who's the genetic counselor, who is the project manager for the study. All the results are shared with the participant on the day that she comes, and they're actionable. We don't have the sequencing results for a week, but we definitely have the MRI results. And so if we do see something on the MRI, they do meet with the NIH collaborating oncologists, and then we at least create a management plan. Now, if everything is normal, we try to collect the placenta to rule out confined placental mosaicism. And then we establish a plan for follow-up evaluation yearly for up to 5 years. Okay, so this is what we're talking about. I want to orient you. Here are human chromosomes 1 through 22, the X and the Y. These are fragments, again, that are mapped to each of these chromosomes. And there are Z-scores, and there's a normal value here. I don't know if you can see, there are little green lines here. Those are the normal boundaries for the Z-scores. So even if you know nothing about genetics, you know that this is a highly irregular pattern. You've got excess DNA fragments here on chromosome 6, on chromosome 8, on chromosome 9. And you have missing fragments on chromosomes 10, 11, 13, 14, 16, 17, and 22. So again, if you know nothing, this is what we call the sawtooth pattern that is highly suggestive of malignancy. This is coming from one of our earliest participants, a 21-year-old woman in her second pregnancy, completely asymptomatic, 28 weeks gestation. By the time she came to the NIH, she had non-reportable cell-free DNA results. And because so many OBGYNs don't know about this, they just keep repeating the cell-free DNA tests, usually with several different laboratories. And that's not the way you should proceed. We also find that many women nowadays are declining diagnostic testing, as she did. So she came into the NIH. We do a whole body MRI study. It is safe to do during pregnancy. There is a little fetus in there. See the head down there. So there's the fetus, her liver, her heart. And there's something here that's about the size of a grapefruit. definitely abnormal. So she has this major mass in her abdomen at 29 weeks of gestation. They did a biopsy and it was inconclusive. So they decided not to do anything until they could get a better quality tissue sample. So we don't necessarily recommend delivering these babies early. It's actually better to treat the mother while the baby is still in the womb and try to get to as close as term as possible. But in her situation, it was such a large tumor and they didn't have a diagnosis. They did an elective cesarean section. And at the time, the left ovary was also enlarged with tumor. So they did a left salpingo-oophorectomy. And the pathology was under a lot of discussion. They finally said it was Ewing sarcoma, which, you don't think of it in the abdomen, you don't think of it on the ovary. So it was a highly atypical tumor. She received chemotherapy, surgery, and radiation. And so this is what a normal profile looks like. So this is her post-treatment. Again, the bands are a little bit narrower here, but you don't see the sawtooth. And these are copy number variants. So some of these like little individual lines, those are perfectly normal. Okay, now we get to the test part. All right, take a look at this one. Sorry, look at number 1. Raise your hand if you think this is cancer. Okay, nobody thinks that's cancer. What about this one, number 2? All right, very good. Number 3. Anybody think this is cancer? Okay, look at this. This very interesting polymorphism here. Anybody think that's cancer? Okay, good. You've been paying attention. But they all have cancer. So the worst usually that we see is colon cancer. Usually very abnormal. It's unbelievable what we've seen in our colon cancer cases. Women are asymptomatic, normal LFTs, they've got metastases in the liver. It's really scary. This is a case of B-cell lymphoma that was very, very subtle. Honestly, we thought it was a normal profile too. We agreed with you. We said, But our wonderful radiologist said there was something he saw. It wasn't a typical lymphoma. He didn't like it. So he recommended that we do a PET scan after she delivered, and it lit up like a Christmas tree. So she was able to have surgery. We actually were able to study, she had surgery at the NIH, so we were able to study her tumor. And this woman, we knew this looked a little bit shaggy. We were not happy with that one. And we weren't sure. We knew that she had ITP, and a lot of these women with hematologic abnormalities do have a little bit of abnormality just because the DNA is more fragmented than usual. But she turned out to have breast cancer. So the patterns are not always revealing. For some of them, they are. Okay, what about this one? This is your final exam now. This is a woman actually came to us at 16 weeks. I'm not having a good tech day, but you can see here, it's chromosome 4 and chromosome 15. Something's odd there, right? It's not that nice, tight band. She's missing sequences on chromosome 4. She's got extra sequences on chromosome 15. It's not a balanced translocation. It's imbalanced. We had her come back. She had completely normal MRI. We had her come back close to term. It's still there. Whatever it is, it's still there. Very, very healthy woman, very fit. I saw her, so like, I don't know what's going on. We saw her for her 1-year follow-up, so 14 months postpartum. So it's clearly maternal, whatever it is. And we've asked the hematologist to get involved. We didn't know, perhaps was she a mosaic? So we ended up doing a skin biopsy on her to see, was it in her skin as well? It was not. So it's in the blood, we think. It's in her hematopoietic system, and we think that she may have some sort of clonal hematopoietic abnormality that may be a pre-leukemic state. This is why research is so exciting, because we're going where no one has gone before. No one has really looked prospectively at people like this who are asymptomatic. So it's clearly there. And, you know, we are going to follow her. We've actually recommended that her primary care physician follow her CBC, and then she'll come back next year and we'll probably get a bone marrow then just to see what's going on. So summary of the second part of the talk. We're done almost. Maternal cancer is a rare but increasingly recognized explanation for non-reportable or discordant NIPT results. I didn't say, but I will say now that about 60%, 60% of the women who come to us with our enrollment criteria do get diagnosed with malignancy. So this is a real finding. In fact, the oncologists on our team, when I first proposed the study to them, they thought I was out of my mind. They just like, you're not going to find any cancer. And now they are believers. And so our goal is really to get we're hoping for, I think we're in our 70s now, because of course we started the study right before the pandemic, then the NIH Clinical Center shut down. So recruitment has not been, as now it's really picked up, but we'll probably get 100 prospective participants, and the trend is definitely keeping up. We've also had our story reported on NPR. So we expect that we will have more participants and get this published, at least the initial part of the study. We've inadvertently shown proof of principle for liquid biopsies. We didn't know if it would work. We have been doing a lot of outreach and have written about the power of this. And we hypothesize that detecting and treating maternal malignancies before the development of symptoms will improve health and extend life. And certainly the data from obstetrics suggests that pregnancy is not a reason to delay cancer treatment, especially in third trimester. And so that's why I say the earlier, the better for mom, and the first part was for baby. So this intersection between newborn medicine and genetics, I think the future is bright. There's certainly advances in ultrasound imaging, but we're moving to a stage where we're getting a lot of information from cell-free DNA, either with whole exome sequencing, whole genome sequencing, and I didn't get a chance to talk about cell-free mRNA circulating the maternal blood, but there's a lot of potential there to predict who will develop preeclampsia, who will deliver prematurely, et cetera. We talked about prenatal precision medicine, and I think obviously the next big area is going to be AI, deep learning, GPT-4. It's really unbelievable how fast that is going. So I'd like to acknowledge the Identify team. Tina Annunziata is our oncologist who's a specialist in women's malignancy. Ashkan Malayeri is our radiologist who's just awesome. We mentioned Amy Turov. And then my laboratory team, you'll hear a little bit more about them later on. And we have some external collaborators as well. So I want to thank you for your attention, and I hope